Welcome back to the deep dive. Today we are taking on, well, a silent giant. We're aiming a massive stack of research at a condition that is, statistically, the most common cardiovascular disease on the entire planet.
And what's so strange about it is that even though it's the most common, it's also the one that manages to sneak up on millions of people.
Because it's silent.
Exactly. Silence is its main weapon.
Yeah, and I have to admit, before I really, dug into the source material for this, my own mental model of high blood pressure was, let's call it optimistically simple.
I think we've all been there.
I just thought of it as a plumbing issue. You've got pipes, your arteries, you've got a pump, the heart. And if the pressure gets too high, you open a valve, lower the pressure, simple physics.
Oh, only. If it were that simple, this wouldn't be such a global health crisis. That's really the core message from the text we're diving into today.
Which are?
We've got the heavyweights.
Mm-hmm.
First, Katsung and Trevor's Basic and Clinical Pharmacology, specifically the chapter on antihypertensive agents. And we're pairing that with Goodman and Gilman's The Pharmacological Basis of Therapeutics, their chapter on the treatment of hypertension.
The gold standards.
Absolutely. And the central tension they both unpack is that hypertension isn't just high pressure in a pipe. It's what you'd call a maladapted regulatory state.
Maladapted regulatory state. Okay, that sounds a lot more biological and a lot less like a clogged pipe.
It is. The body thinks that the high pressure is normal. It's reset its own internal thermostat, what we call the set point, to a dangerously high level.
So when you try to fix it?
The body doesn't say thank you. It fights back. You actively resist the treatment because it believes it's defending its normal state, its homeostasis.
Wow. Okay, so that's the hook for this whole deep dive. We're not just fixing a machine. We are, in a sense, entering into a high-stakes negotiation with a biological system that is actively pushing back against us.
It's a physiological standoff. That's a great way to put it.
So let's lay out our guides for this negotiation. You mentioned Katsung and Goodman and Gilman. How do they complement each other?
I like to think of Katsung as our clinical architect. It gives you the scaffolding, the organization, the flow charts. It tells you how to build a rational treatment plan step by step.
And Goodman and Gilman?
If Katsung is the architect, Goodman and Gilman is the molecular mechanic. It goes deep under the hood. It's going to tell us exactly which ion channel is popping open, the kinetics of the receptors, the real, systems level reasoning behind it all.
A perfect pairing. And, of course, a quick disclaimer. This is a conceptual map. We are synthesizing, we're building a framework to help you understand the landscape.
Right. This is not medical advice.
And for the students listening, this is definitely not a substitute for actually sitting down and reading the chapters.
Reading is absolutely essential. We're here to make that reading click, to make it stick.
Okay, let's start with that foundation then. The architect, Katsung, lays out what it calls the hydraulic equation of the body. What is it that actually determines our blood pressure?
It all boils down to one fundamental formula. And honestly, it rules the entire cardiovascular system. It's arterial pressure equals cardiac output, or CO, multiplied by peripheral vascular resistance, PVR.
CO times PVR. That's it.
That is the whole game. Every single drug we're going to talk about today, every side effect, every strategy is just an attempt to manipulate one of those two variables.
So break those down. Cardiac output is what?
Simply the volume of blood, the pump, the heart, pushes out every minute. Liters per minute.
And peripheral vascular resistance, PVR.
That's how tight the pipes are squeezed. It's the resistance the heart has to push against.
And Katsung points to 4 specific anatomical sites that control these variables. He calls them the 4 horsemen of regulation.
Oh, I love that visual. It's so good. Yes, the 4 horsemen. Horseman number 1, the arterioles.
Okay.
These are your resistance vessels. Think of them as the muscular little stopcocks all throughout your circulation. If they clamp down, PVR skyrockets and pressure goes up almost instantly.
So the arterioles control the squeeze.
Exactly. Horseman number 2, the postcapillary venules. Now, these are your capacitance vessels. They're like storage tanks.
Storage tanks, I usually just think of veins as return pipes.
Well, most people don't realize that the venous system holds the majority of your blood volume at any given moment. If these venules constrict, they squeeze that stored blood back toward the heart.
Oh, like squeezing a toothpaste tube from the bottom up?
Precisely. That increases the preload, the amount of blood filling the heart, which forces the pump to push more out. So the venules control the return volume.
Okay, so squeeze and return. What's number 3?
Number 3 is the heart itself, the pump. Simple questions. How fast is it beating? And how hard is it contracting with each beat? That directly affects cardiac output.
Makes sense. And the 4th horseman, you said this one was the most cunning.
A kidney. Without a doubt, the kidney is the ultimate arbiter of the total volume in the system.
How much fluid is actually inside the pipes?
Correct. More fluid in a closed system equals higher pressure. And while the other three horsemen act in seconds to minutes, the kidney plays the long game. It is the master of long-term volume control.
Arterioles, venules, heart, and kidney. Okay. Before we get into how we drug these four, let's talk about the stakes. I was looking at the epidemiology section in Goodman and Gilman, and they mentioned something called the rule of halves. It sounds, well, a bit depressing.
It is sobering. It really highlights how, despite having all these amazing drugs, we as a society are still struggling.
So what is it?
The data they cite suggests that roughly 81.5% of people with hypertension are actually aware they have it, which, is an improvement from the old days.
Okay, so most people know.
But of those who know, only about 75% are actually being treated. And then here's the real kicker. Of those being treated, only about 52.5% are considered controlled.
Wow. So you're saying literally half the people walking around with a diagnosis of hypertension do not have it under control?
Right. And we have to be really careful with that word, controlled. We, in medicine, draw a line in the sand, usually 140 over 90 milliliter Hg. If you're below that, you're good. If you're above, you're hypertensive.
But biology doesn't really care about our neat little lines.
Not at all. The risk of something bad happening doesn't magically appear at 141 over 91.
So the risk doesn't just flatline once you dip below the cutoff.
Far from it. The data shows that the risk of cardiovascular death actually begins to double with every 20 over 10 increments, starting from a baseline as low as 115 over 75.
Wait a minute, 115 over 75, I would consider that optimal, maybe even on the low side of normal.
It is optimal, but that's the point. The risk curve is continuous. As you slowly creep up from 115 to 135, your risk is climbing steadily, even if you don't have the official diagnosis yet.
And this was the big bombshell from the SPRINT trial, right? Back in 2015.
That was the earthquake. The SPRINT research group ran a massive trial. They compared a standard blood pressure target of 140 systolic against an intensive target of 120 systolic.
And the intensive group, the lowers better group, won.
They won significantly. The group that targeted 120 had 25% fewer cardiovascular events, heart attacks, strokes, heart failure, and they had lower all-cause mortality.
25% is a huge number.
It shook the medical world. It completely challenged the good enough approach that had been standard for decades. It suggested that being more aggressive actually saves lives.
But I seem to recall there was a bit of a controversy there, something about how they actually measured the pressure in that trial.
That is a fantastic and crucial point. SPRINT used a technique called unattended automated office blood pressure.
Which means?
Basically, they put the patient in a quiet room, alone, with an automated cuff. The machine took multiple readings without a doctor or nurse in the room, no white coat anxiety.
So it gets rid of the stress of having a person there.
Exactly. And that method generally yields lower, probably more accurate numbers than the typical rush checkup where a nurse is pumping up the cuff while asking you about your weekend. So a SPRINT 120 might actually be closer to a real-world 130, but the principle holds.
The principle being that lower is generally better for the plumbing?
Precisely.
Okay, so the stakes are incredibly high. Good enough might still leave you very vulnerable. So why is this so hard to fix? You said the body fights back. Let's really unpack that set point concept. This feels like the core of the whole problem.
This is absolutely the most critical concept to grasp if you want to understand these drugs. In a healthy person, if your blood pressure spikes, you get stressed, you'd eat a whole bag of salty chips. Your body has powerful mechanisms to bring it right back down to normal.
Yeah.
In a hypertensive patient, those same mechanisms are still working perfectly. The problem is they are defending the wrong number.
So it's like a thermostat in your house that's broken and stuck at 85 degrees Fahrenheit if you try to cool the house down by opening a window.
The furnace just kicks on even harder to get it back up to that scorching 85. It thinks that's normal.
That is a perfect analogy. So what are the body's furnaces? What are these defense systems?
There are two main ones. You have the short-term defense, which is the barrier reflex. That's the neural system. And then you have the long-term defense, which is the kidney. And it's hormonal messenger, the RAAS system.
Let's start with the short term, the bare flex. This is happening in milliseconds, right? It's neural.
Yes, it's hardwired. The classic way to explain it is with the posture test. Imagine you're lying on the couch, totally relaxed, and you suddenly jump up to answer the door.
Okay.
Gravity instantly pulls a significant amount of your blood down into the veins of your legs. We call it venous pooling.
So less blood is getting back to the heart.
Immediately. Less blood returns, so cardiac output drops, and your arterial pressure plummets.
Which logically should mean I get dizzy and faint.
And if you didn't have a Barriflex, you would. Your brain would lose perfusion, and you'd hit the floor every time you stood up. But you don't, because of tiny stretch receptors in your carotid sinus in your neck and in your aortic arch. They sense that drop in pressure, that lack of stretch, instantly.
And they send a signal to the brain.
They actually stop sending an inhibitory signal. They're normally telling the brainstem to chill out. When pressure drops, they go quiet. This disinhibition unleashes the sympathetic nervous system.
Oh, fight or flight system.
It just explodes into action. It sends signals to clamp down on those arterioles, cranking up PVR, and it tells the heart to beat faster and harder, cranking up CO. Pressure is restored before you even realize it happened.
Okay, that's an amazing survival mechanism. So why is this a problem for us when we're treating a hypertensive patient?
Because if we give a drug, say a powerful vasodilator, that rapidly drops their blood pressure, the baroreceptors don't know we're trying to help. They just scream, "Emergency! Pressure is critically low."
They think the patient's bleeding out or something.
Exactly. So they trigger a powerful reflex tachycardia.
The heart starts racing.
It starts pounding out of their chest. We've successfully lowered the resistance, the PVR, but the body just jacked up the cardiac output to compensate. The net result, the blood pressure barely moves, but now the patient feels awful, anxious, and has palpitations.
That's the set point fighting back in real time.
That's the short-term fight.
Okay, so that's the rapid response. But you said the kidney is the ultimate arbiter. What's the long game here?
The kidney controls the volume. You can play with the heart and the vessels all you want, but if the kidney decides to hold on to salt and water, blood pressure will eventually win. And this is all governed by the RAAS.
The renin-angiotensin-aldosterone system. This is probably the most famous cascade in all of pharmacology.
It's certainly a big one, and it all starts with a molecule called renin.
Which comes from the kidney.
The kidney releases renin when it's unhappy, and Goodman and Gilman detail 3 specific triggers for renin release. Number 1, low pressure in the renal arterioles themselves. The kidney can feel its own blood pressure.
Wow, okay.
Number 2, low sodium delivery. There are special sensing cells in the kidney called the macula densa. If they don't taste enough salt in the fluid passing by, they signal for renin. And number 3, direct sympathetic stimulation via beta-1 receptors.
So if the kidney feels low pressure, low salt, or high stress, it dumps renin into the bloodstream.
Right. And renin is an enzyme. Its only job is to find the big protein floating around called angiotensinogen, which is made by the liver, and chop a piece off of it.
Creating what?
Creating angiotensin I.
Yeah.
Now, angiotensin I is biologically inert. It's just a precursor. It doesn't do anything yet.
Okay.
But then it circulates through the body. When it gets to the lungs, it meets another enzyme. This one's called ACE, angiotensin converting enzyme.
And ACE turns angiotensin ion into...
Angiotensin II.
And this is the bad guy.
Angiotensin II is the master switch. It is one of the most potent vasoconstrictors known to biology. It immediately clamps down on vessels everywhere to raise PVR, but it doesn't stop there. It also calls in backup.
Backup from where?
It flies over to the adrenal gland, which sits on top of the kidney, and stimulates it to release another hormone, aldosterone.
And aldosterone is the hoarder.
The ultimate hoarder.
Oh, yeah.
Aldosterone works on the very last part of the kidney tubule, the collecting duct. And it tells those cells, do not let a single molecule of sodium leave this building. It forces the body to retain sodium.
And where sodium goes, water follows.
Always. So now, thanks to angiotensin II, you have tightly constricted vessels, and thanks to aldosterone, you have an increased blood volume filling those tight vessels. It is a devastatingly effective dual threat mechanism for raising blood pressure.
It's actually an incredibly elegant system if you're trying to survive, say, bleeding to death on the savannah.
Exactly. If you're a hunter-gatherer and a saber-toothed tiger rips open your femoral artery, the RAA system saves your life. It clamps your vessels and holds onto every drop of fluid.
But in modern humans, sitting on a couch with stiff arteries and a high-salt diet.
That same life-saving system becomes maladaptive. It's slowly and silently killing us.
Okay, so that's the landscape. The body is defending this high pressure with fast neural reflexes and a powerful long-term hormonal cascade. Our mission, then, is to dismantle these defenses without triggering a catastrophe. Let's open the toolkit. Section 2, the volume lever. Diuretics.
Diuretics are often the first line of defense, especially in certain populations. But they are surprisingly and beautifully complex.
I mean, on the surface, it seems simple. You give a drug that makes you pee more. You lose volume, so the pressure goes down.
Right. If you ask a first-year medical student how a diuretic lowers blood pressure, that's the answer you'll get. It makes you pee, you lose volume, cardiac output drops, and pressure goes down.
Less fluid in the pipe, less pressure. Makes sense.
And that is absolutely true for the first few weeks. That's the acute phase. You deplete sodium, water follows, blood volume drops, cardiac output drops. But here's the mystery, what Goodman and Gilman calls the time paradox.
Ooh, I like that.
If you look at a patient who's been on a thiazide diuretic for, say, 6 months, their blood volume has almost completely returned to normal. Their cardiac output is back to where it started.
Wait, what? So if the volume and the cardiac output are back to normal, why is their blood pressure still low? It should have gone back up.
Because in the chronic phase, the long-term benefit of the diuretic comes from a drop in peripheral vascular resistance. The vessels themselves have actually relaxed.
But why? If the drug's main job is just to make you pee, why are the blood vessels relaxing 6 months later? That seems totally unrelated.
This is where Goodman and Gilman offer some really fascinating speculation. The leading theory is that chronic high sodium levels make the smooth muscle cells and blood vessel walls stiff and hyperreactive to things like adrenaline.
So sodium essentially waterlogs the vessel walls.
In a sense, yes.
Yeah.
It changes the intracellular ion concentrations. So when you deplete the body's total sodium stores over a long period of time, even just slightly, you de-stiff the vessels. They become more flexible, more compliant, they relax.
That is fascinating. So you're not just draining the pipe, you're actually changing the material properties of the pipe itself by altering its sodium content.
That seems to be the main mechanism. There are other theories too. One involving the opening of calcium-activated potassium channels, which would hyperpolarize the muscle cells and make them harder to contract. But the big takeaway is this. Long-term, diuretics are actually vasodilators in disguise.
A very clever disguise. Okay, let's talk about the specific drugs. The standard seems to be the thiazide class, but Katsung highlights a bit of a rivalry here. Hydrochlorothiazide, HCTZ versus clothalidone.
It is a classic case of medical inertia versus the evidence. HCTZ is one of the most prescribed drugs in the world. It's the default diuretic in many combination pills in the U.S.
But Katsung says that's a mistake.
Katsung is very clear on this. For hypertension, chlorthalidone is preferred.
And why is that? Is it just stronger?
It's all about the duration of action. HCTZ has a relatively short half-life. It works great for, 12 to 18 hours. But by the time the patient wakes up the next morning, its effect is wearing off.
And blood pressure naturally spikes in the morning.
Exactly. We call it the morning surge. And that's a period of high risk for strokes and heart attacks. It's also when HCTZ is at its weakest.
So chlorthalidone lasts longer.
Chlorthalidone is a marathon runner. It has a very long half-life, providing smooth, consistent 24-hour blood pressure control. The large outcome trials show it's actually better at preventing cardiovascular events than HCTZ is.
So many doctors are prescribing HCTZ out of habit, but chlorthalidone is really the evidence-based winner for hypertension.
That's a fair summary.
What about the loop diuretics? Furosemide, Lasix? We hear about those all the time in hospital settings.
Furosemide is the heavy artillery. It works on a part of the kidney called the loop of Henle, which is responsible for a massive amount of sodium reabsorption. So it's incredibly potent. It will strip fluid off a patient very, very quickly.
But not for simple hypertension.
For simple hypertension, it's total overkill. It's too short-acting and too powerful. You get these wild swings in fluid status. We reserve loop diuretics for patients in acute heart failure who are literally drowning in fluid, or for patients with severe kidney failure, a low GFR, where thiazides just aren't strong enough to work anymore.
So thiazides for the average outpatient, loops for the sickest patients. But there's a cost to all this, right? You can't just move that much salt and water without some consequences. Electrolytes.
The big one is potassium. Hypokalemia, low potassium. Both thiazides and loops are notorious for causing the body to waste potassium in the urine.
And can you walk us through the mechanism for that? It seems counterintuitive. Why does losing sodium make you lose potassium?
It's a fascinating bit of physiology. It all happens in the collecting duct, which is the very end of the line in the kidney nephron. When you block sodium reabsorption upstream with a thiazide, a huge wave of extra sodium arrives at this final checkpoint. The kidney panics and tries to snatch some of that sodium back at the last second. But the channel it uses there is an exchange channel. To pull one positively charged sodium ion in, it has to spit a different positively charged ion out to maintain electrical balance.
And that ion is potassium.
That ion is potassium. So more sodium delivery to the end of the tubule equals more potassium wasting.
And low potassium is dangerous because it's what keeps your heart rhythm stable.
Right. If your potassium gets too low, you are at a serious risk for fatal cardiac arrhythmias. It's something we have to monitor very closely.
There are also metabolic costs, right? I've heard diuretics can trigger gout.
Yes, gout is a classic one. Thiazides can cause uric acid retention. It turns out the kidney uses the same organic acid transporter to actively secrete the diuretic drug into the urine as it uses to secrete uric acid out of the body.
So they're competing for the same exit door.
Exactly. The transporter is busy pushing the diuretic out, so uric acid gets left behind and builds up in the blood. If a patient comes into your clinic with a swollen, red, excruciatingly painful big toe a few weeks after starting diuretic, you know what happened.
Okay, so that's the volume lever. Powerful, but with some tricky side effects. Let's move to section 3, the hormonal lever. We've identified the RAAS system as the long-term villain. How do we shut it down?
We have two main classes of weapons here. The first are the ACE inhibitors. These are the drugs that end in prol, like lisinopril or ramepral.
And the other?
The ARBs, or angiotensin receptor blockers. These are the sartans, like losartan or valsartan.
Let's start with the ACE inhibitors. Their job is to block that ACE enzyme in the lungs, stopping angiotensin II from ever becoming the master switch, angiotensin II.
Correct. And they are incredibly effective at lowering blood pressure. But ACE inhibitors have a fascinating side quest that is totally unique to them.
A side quest.
You see, the ACE enzyme, its full name is angiotensin converting enzyme, but that's not its only job.
Yeah.
It's also a destroyer. It's the primary enzyme that breaks down and gets rid of another molecule in the body called bradykinin.
Bradykinin, what does that do?
Bradykinin is a very potent vasodilator. So, under normal circumstances, ACE is constantly cleaning it up, keeping it in check. But if you inhibit the ACE enzyme...
The trash collector goes on strike.
Exactly. And bradykinin starts to pile up.
Okay, so if bradykinin is a vasodilator, having more of it floating around should actually help lower blood pressure even more, right?
It does.
Yeah.
The extra bradykinin contributes to the blood pressure lowering effect. It's a helpful bonus. However...
There's always a however.
Bradykinin is also a potent irritant in the bronchial tree. It sensitizes the cough reflex nerves in the lungs, and this leads to a dry, hacking, persistent, non-productive cough in up to 20% of patients who take it.
The famous ACE cough.
The one and only. It can be absolutely maddening for patients. It doesn't respond to cough syrup because it's a chemical irritation, not an infection. And in very rare but very severe cases, this bradykinin accumulation can cause angioedema.
Which is?
Rapid, life-threatening swelling of the lips, tongue, and throat. It's a medical emergency.
Okay, so if the cough is driving a patient crazy, or God forbid they have angioedema, we switch them to an ARB, an angiotensin receptor blocker. How is that different?
The ARB is more of a sniper. Instead of stopping the production of angiotensin II, it just lets the body make it. Then it goes directly to the receptor on the blood vessel, the AT1 receptor, and physically blocks the docking port. It just stands in the way.
And crucially, it doesn't touch the ACE enzyme.
Right. It leaves ACE alone to do its job of breaking down bradykinin. So with an ARB, you get the same beneficial blood pressure lowering from blocking angiotensin II's effects, but you get absolutely zero cough.
This brings up a question that I think a lot of people must have. If the ARBs do the same job, but without the risk of that horrible cough, why aren't they just the first choice for everyone? Why do we even bother with ACE inhibitors anymore?
That is the billion-dollar question, and it's a source of a lot of debate. Goodman and Gilman points to the massive OnTarget trial, which compared an ACE inhibitor and an ARB head-to-head.
And what did it find?
It showed that ARBs are not superior to ACE inhibitors in terms of efficacy preventing heart attacks and strokes. They are essentially equal. They're just better tolerated because of the cough issue.
So why do we still use ACEs?
Honestly, a lot of it is historical. ACE inhibitors came out first. They went generic first, so they became much cheaper, and doctors just got into the habit of prescribing them. You could make a very strong clinical argument, though, that an ARB is a cleaner drug.
Now, there is a specific type of patient where these RAS drugs are considered absolute gold, right? It's not just about blood pressure.
Absolutely. This is a critical takeaway. We're talking about patients with diabetes and patients with chronic kidney disease, or CKD.
What's so special about them?
In a diabetic kidney or any damaged kidney, the pressure inside the tiny filtration unit, the glomerulus, is often pathologically high. It's like a tiny pressure cooker. This high pressure forces protein to leak out into the urine. We call that proteinuria, and that process itself further damages the kidney over time.
A vicious cycle. And how do ACEs and ARBs help that?
They do something magical. They specifically cause vasodilation of the efferent arteriole. That's the exit pipe from the glomerulus.
So they open the escape valve.
Precisely. By opening up the exit, you lower the pressure inside the cooker. This reduces the proteinuria and dramatically slows down the progression to kidney failure. It's so important that we often put diabetics on a low-dose ACE or ARB, even if their systemic blood pressure is normal, just for this kidney protective effect.
That's a huge point. We're using them as organ protectors, not just as blood pressure pills. Okay, now here's a logical trap I can see a student falling into. If ACE inhibitors are good and ARBs are good, why not give both? Super suppress the RAAS system.
The combination trap. It makes perfect logical sense on paper, but in biology, it's a disaster.
Happens.
Clinical trials tested this exact idea. The result: no extra benefit in preventing heart attacks or strokes, but a massive increase in serious side effects, especially acute kidney failure and dangerously low blood pressure.
So the rule is?
The rule is simple and absolute. You never ever combine an ACE inhibitor with an ARB. You pick one lane and you stay in it.
Got it. One or the other, never both. All right, let's move on. Section 4, the tone lever. Calcium channel blockers or CCBs?
Now we're getting into the direct manipulation of muscle tone. Any kind of muscle contraction, whether it's in your bicep when you lift a weight or the smooth muscle wrapped around your arteries, requires calcium.
Calcium is the trigger.
It's the trigger. Calcium flows into the muscle cell through special channels called L-type channels, and that influx of calcium kicks off the whole chain of events that makes the muscle squeeze. So if you can block that channel...
No calcium in, no squeeze.
No squeeze. The muscle relaxes, and when the muscle wrapped around an artery relaxes, the pipe gets wider, peripheral resistance drops, and blood pressure falls.
Seems pretty straightforward.
It is, but here's the deep dive nuance. Not all calcium channel blockers are created equal. There is what we call the great divide in this class of drugs.
A great divide.
Yes, between the dihydropyridines and the non-dihydropyridines.
Okay, those are some mouthfuls. Let's break that down.
Let's start with the dihydropyridines. These are the ones that almost always end in tadipine, amlodipine, difidipine, philodipine.
The andipines. Got it.
These drugs are vasoselective. They are much, much better at blocking the calcium channels in the smooth muscle of blood vessels than they are at blocking the channels in the heart. They are potent vasodilators.
Okay, so they target the pipes. What about the other group, the non-dihydropyridines?
That's basically two drugs you need to know: verapamil and diltiazem. These are more cardioselective. They block the channels in the vessels a little bit, but they really love to block the calcium channels in the heart muscle itself.
And what does that do to the heart?
It directly slows the heart rate down by acting on the pacemaker cells in the SA and AV nodes, and it also reduces the force of contraction.
This distinction sounds like it's incredibly important for safety.
It is life or death important.
Yeah.
Let's go back to the dihydropyridines, like amlodipine. If you give a drug that powerfully dilates all the arteries, what does the buroflex do?
We just learned this. It panics. The brain senses the pressure drop and it tells the heart to speed up to compensate.
Right. So a very common side effect of a drug like amlodipine is a reflex tachycardia. The heart rate goes up. It's usually manageable with the modern long-acting drugs.
But it can be a problem.
It can be a huge problem. In the old days, we had these short-acting nifedipine capsules. A doctor would have a patient with very high pressure bite into one and swallow it. It would drop their pressure so fast and so hard that the resulting reflex tachycardia was violent enough to actually cause heart attacks in some patients.
Wow.
We never ever use short-acting nifedipine for hypertension anymore because of that risk. Only the slow, sustained-release versions.
Okay, so amlodipine can make the heart speed up as a reflex. What happens with verapamil, the cardioselective one?
Well, verapamil puts a direct brake on the heart, so when it dilates the vessels and pressure drops, you don't get a reflex tachycardia because the drug is chemically preventing the heart from being able to race.
That sounds like a benefit. It's preventing the body's own counterattack.
Yeah, it sounds great, right? Very peaceful. Until you make the mistake of combining it with another drug that slows the heart, like a beta blocker.
Ah, I see where this is going.
If you give a patient verapamil A&D, a beta blocker, you have now put two very heavy feet on the heart's brake pedal at the same time. You can cause complete heart block. You can literally stop the heart.
So that's a never event in medicine. Never combine verapamil or diltiazem with a beta blocker.
It is one of the cardinal sins of cardiovascular pharmacology. Absolutely never do it. Amlodipine plus a beta blocker, that's a great combination. The beta blocker actually helps by preventing the reflex tachycardia from the amlodipine.
But verapamil plus a beta blocker is dangerous.
Got it. Before we move on, what's the most common side effect people complain about with amlodipine? I hear about swollen ankles all the time.
Ah, yes, peripheral edema. And the mechanism is just fascinating. Amlodipine is a much more powerful dilator of the arterioles, the tiny inlet pipes leading into the capillary beds, than it is of the venules, the outlet pipes.
So you have more flow coming in than can get out. Exactly. You have high pressure flow coming in, but a relatively constricted exit. So the pressure builds up inside the tiny capillaries, especially in the feet and ankles because of gravity. That high pressure literally forces fluid out of the blood vessels and into the surrounding tissue.
So it's not a kidney problem, it's not salt retention.
No. And that's a crucial point. It's purely a hydrostatic pressure mismatch. That's why giving a diuretic often doesn't help amlodipine-induced edema very much. The best cure is actually to add an ACE inhibitor, which tends to dilate the venual side and balance the pressures, or you just have to lower the dose.
That is a fantastic clinical pearl. Okay, that leads us perfectly into section 5, the neural lever, the sympatholytics, and specifically a class you called a fall from grace in the outline, the beta blockers.
It really is a fall from grace. 20, 30 years ago, if you were diagnosed with high blood pressure, there was a very good chance the first pill you walked out with was a beta blocker, like atenolol or metoprolol. It was the absolute standard of care.
And their mechanism seems logical. They block the sympathetic fight-or-flight signals to the heart.
They do two things. They block beta-1 receptors on the heart, which slows the heart rate and reduces the force of contraction, lowering cardiac output. And they also block beta-1 receptors on the kidney, which shuts down that renin release we talked about.
So they slow the pump and they stop the RAAS system at its source. That sounds really effective.
And it is effective at lowering the number you see on the blood pressure cuff in the arm. No question.
Mm-hmm.
But when we started looking at the data from massive long-term outcome trials, a really disturbing trend emerged.
What was that?
Compared to CCBs, ACE inhibitors, or diuretics, the beta blockers were less effective at preventing strokes.
Wait, how can that be? If the pressure in the arm cuff is lower, shouldn't that protect the brain just as well?
This is where Goodman and Gilman gets into a fascinating concept called central aortic pressure. It turns out that the pressure in your brachial artery, in your arm, isn't always the same as the pressure in your aorta, right as it leaves the heart.
And the brain is seeing the aortic pressure.
The brain, the kidneys, the heart itself, they all see that central pressure. And the theory is that beta blockers, for complex hemodynamic reasons, might lower the pressure in your arm more than they lower the pressure in the central aorta. So the vital organs were still getting hammered by higher pressures than we thought.
So the guidelines shifted.
They shifted drastically. Beta blockers are no longer considered a first-line therapy for what we call uncomplicated hypertension. You don't just start someone on metoprolol anymore, simply because their pressure is 150/95.
But they're not gone completely. They still have a very important niche.
A very specific and very important niche. We now use them for what are called compelling indications. If a patient has heart failure, absolutely, beta blockers are life-saving because they rest an overworked heart. If they just had a myocardial infarction, a heart attack, they're essential for preventing fatal arrhythmias and future events.
But if it's just pure hypertension with no other issues?
You reach for the thiazide, the ACE inhibitor or ARB, or the calcium channel blocker first.
Okay, one last group in this category, just briefly. The alpha blockers, like prazosin.
The forgotten cousin.
Mm-hmm.
They work by blocking alpha-1 receptors on the vessels, which causes powerful vasodilation. They work, but they have a really nasty side effect called the first dose phenomenon.
Which is?
The first time you take the pill, the vasodilation can be so profound that when you stand up, your blood pressure completely craters and you faint. Massive orthostatic hypotension. We mostly just use them now for older men who have both high blood pressure and an enlarged prostate, or BPH. The alpha blockade helps with both problems. Two birds, one stone.
A very specific niche. Okay, so we've toured the entire toolkit. We have diuretics for volume, RAAS inhibitors for hormones, CCBs for tone, and beta blockers for neural input. Now comes the reality of treating a real, complex human being. Section 6, the Hydra effect.
This brings us right back to our central theme for the whole day, the body fights back. And the Hydra effect is the perfect metaphor for it. Like the mythical beast, you cut off one head and two more grow back in its place.
Give us a clear pharmacological example of this Hydra.
Okay, let's say you give a patient a simple, direct-acting vasodilator, an old drug called hydralazine. Its only job is to force arteries open.
Okay, so step one, the drug works, arteries dilate, PVR drops, and blood pressure falls.
Right, but what happens next? Step two, the baroreceptors sense that sudden drop in pressure. They scream, emergency, and trigger a powerful reflex, tachycardia. That's one new head, a racing heart, growing back.
And the kidney.
Step three, the kidney also senses the low pressure. It panics and activates the entire RAS system to retain as much salt and water as possible, trying to refill the now empty and dilated vessels. That's the second new head, fluid retention and edema.
So you solved one problem, low resistance, but in its place, you now have a racing heart and swollen legs. You could be back where you started or even worse off.
Exactly. This is why monotherapy using just one drug, especially vasodilator, often fails over the long term. The body's compensatory loops are just too powerful.
So the logic of modern treatment is to anticipate this. It's strategic polypharmacy.
We are building a team of drugs specifically designed to neutralize the Hydra's counterattacks.
What does that classic team look like?
The classic triad works like this. 1. You give the vasodilator, like a CCB or hydralazine, to lower resistance. That's your primary tack. 2. You add a beta blocker specifically to prevent the heart from racing. You've chopped off the tachycardia head before it can grow.
And for the fluid retention.
3. You add a diuretic to prevent the kidney from hoarding salt and water. You've neutralized the volume retention response.
It's like a pincer movement in battle.
Yeah.
You're attacking the problem while also cutting off the enemy's escape routes and reinforcements. You checkmate the body's defenses.
That is the goal. And by hitting 3 different mechanisms, you can often use lower, better tolerated doses of each individual drug, which means fewer side effects, but you get a massive additive or even synergistic effect on blood pressure.
Which is why the guidelines now say,
for anyone with stage 2 hypertension, so that's a pressure over 160 over 100, you don't even bother trying one drug. You start with 2 drugs from different classes, often in a single combination pill, right from day 1.
That leads us perfectly into our final section, section 7, clinical decision-making. Because we don't treat numbers, we treat individual people. So let's run through a few common patient profiles. Patient A, a 55-year-old with type 2 diabetes and hypertension. What's the first move?
Kidney protection is priority number 1, always. You start with an ACE inhibitor or an ARB, no question. You want to reduce that pressure inside the glomerulus that we talked about. It's a 2-for-1 deal. You get blood pressure control and you get long-term kidney preservation.
Okay. Patient B, a 60-year-old African-American male, no other medical problems.
The clinical trial data here is very clear. Statistically, Black patients tend to have what we call a low renin or salt-sensitive physiology. Their hypertension is driven more by volume and vascular tone, and less by an overactive RAAS system.
So an ACE inhibitor won't work as well?
As monotherapy, it's often less effective. So the first-line recommendation is to start with either a thiazide diuretic like chlorthalidone or a calcium channel blocker like amlodipine.
Makes sense. Okay, a trickier one. Patient C, an 80-year-old woman with isolated systolic hypertension. Her top number, her systolic, is 170, but her bottom number, her diastolic, is totally normal, like 70.
This is a classic finding in the elderly, and it's pure physics. With age, the large arteries like the aorta become stiff and calcified. They're like lead pipes instead of flexible hoses.
So they don't stretch.
They don't stretch to absorb the pressure when the heart beats. So the pressure spikes really high. That's your high systolic of 170. But because the vessels don't have that elastic recoil, the pressure then falls off very quickly during the relaxation phase. That's your normal or even low diastolic of 70.
And the SPRINT trial told us we still need to treat that high systolic number to prevent strokes.
We absolutely do, but we have to be very, very gentle.
Why so gentle?
Because the coronary arteries, the little arteries that supply blood and oxygen to the heart muscle itself, fill with blood during diastole, during that relaxation phase. So if you're too aggressive in lowering the blood pressure, and you drive that diastolic number too low, say, you push it from 70 down to 55, you risk starving the heart muscle of its own blood supply. It's called the J-curve phenomenon.
It's a J-curve. So you treat the high 170, but you watch that 70 like a hawk to make sure it doesn't fall too far. What drugs work best there?
Usually low-dose diuretics and long-acting dihydropyridine calcium channel blockers are the answer there. They're very effective at lowering systolic pressure without tanking the diastolic.
Okay. Final scenario. What happens when you've thrown the kitchen sink at a patient? They're on a diuretic, an ACE inhibitor, a CCB, and their pressure is still stubbornly high, resistant hypertension.
The official definition is failure to control blood pressure with 3 different drugs, one of which must be a diuretic. The first thing you do is you have to look for secondary causes. Is there a hidden tumor on their adrenal gland pumping out aldosterone? Do they have severe untreated sleep apnea? Is there a blockage in the artery to their kidney?
But most of the time.
But most of the time. It's the hardest pill for both the doctor and the patient to swallow. It's non-adherence.
They just aren't taking the medication.
Think about it from the patient's perspective. Hypertension is asymptomatic. You feel perfectly fine. Then I, the doctor, give you a treatment that creates symptoms. It makes you have to pee all the time from the diuretic. It gives you a dry cough from the ACE inhibitor. It might cause erectile dysfunction from the beta blocker. It makes you tired. And it costs you money every month.
So you're asking them to feel slightly worse today.
To prevent a stroke that might happen in 10 years. That is an incredibly hard sell for human psychology, which is wired for immediate gratification, not long-term risk prevention.
So the physician's role isn't just to be a prescriber. It's to be an educator, a motivator.
It's sales. You are selling them on the value of their future self. You have to reframe the goal. The goal isn't a better number on a chart. The goal is being able to walk your daughter down the aisle or play with your grandkids without being in a wheelchair from a preventable stroke.
That's a really powerful perspective. All right, let's try to wrap this up. We have covered a massive amount of ground here. From the concept of the set point, to the sniper shot of an ARB, to the mythological Hydra.
To synthesize it all, I think it comes down to this. We have a toolkit. Diuretics for volume, ACEs and ARBs for the hormonal system, CTBs for vascular tone, and sympatholytics for the neural inputs. But the philosophy is what's key. We are not just forcing a number down. We are trying to gently and strategically reset a complex biological system that is actively trying to maintain a dangerous status quo.
Nudging it back to safety. And as we close, we always promise a provocative thought, something for our listeners to chew on.
I want to go back to that J-curve we just mentioned. We have spent this entire deep dive talking about how to lower blood pressure, and the SPRINT trial pushed us to go lower and lower.
Right.
But biology is rarely linear. There's a lot of growing evidence that for certain populations, especially the frail elderly, being too aggressive with blood pressure lowering might actually increase the risk of falls, confusion, and poor organ perfusion.
The lower is better.
Until it isn't. The real art of medicine here is not just treating a number, but treating a whole person and their unique physiology. We are treating perfusion, not just pressure. And that ideal target keeps moving as our evidence continues to improve. It's a constantly evolving science.
A moving target. For those of you who want to see the actual wiring diagrams of the Burr reflex or the receptor kinetics of the ARBs we discussed, please open up Kitsung Chapter 11 and Goodman and Gilman Chapter 28. Use this conversation as your map, but go explore the territory for yourself.
Absolutely. The devil and the real beauty is always in the details.
Until next time, keep the pressure steady. Thanks for listening to The Deep Dive.